Hello everyone, welcome to today's session of monkeypox in pregnancy. So this is a guideline, this is an update which came up in 2023 and this is what we are going to talk about today. And the sources which I have followed is the RCOG guidelines which we will follow for this particular topic. Although it's not very commonly seen, it's a rare thing to see, but still, because this guideline has come up from the RCOG, so it's going to be, sometimes the question may appear in the exam. So it's an important topic, and for all the parts, part 1, part 2, and part 3. Right, I hope the voice is audible now, right? Okay, so yeah, you can let me know in the live chat that if it is audible to you. Thank you. Okay, so now let me start with this. First, we'll start with the epidemiology. So something about the monkeypox virus that is was first identified in the monkeys. That's the name. So it was in 1958, and it's a member of the orthopox virus genus, along with the cowpox virus and the variola virus that causes the smallpox. So it's like a cousin of that. So mpox is a viral zoonosis with a range of animal hosts, mostly rodents and non-human primates. How does it spread? That is more important that we should know. So mode of spreads are, the most commonest one is the direct spread from the vesicular rash, which can come because you are in contact with the person, direct skin to skin contact is there, or maybe because of the sexual transmission. So direct spread from the vesicular rash can be there, or it can be because of the contact with the clothing or the bedding, and it could be the droplet infections, which like a person who has been there in the room, he has coughed, he has sneezed, and that virus has been released as a droplets. Then there is undercooked meat or contact with the infected animals. So any of these, they are the mode of spread. Now, how do we define these cases as? So what are the various definitions which are used? So possible case, when do we say that it's a possible case, right? So whenever a patient has a fever, that is a febrile prodrome fever more than 38 degrees centigrade, chills, headache, exhaustion, muscle fatigue. These are the common symptoms which you can see in the these are the common symptoms which you can see in any of the viral illness. And so there could be muscle pains, myalgia, joint pain, arthralgia, backache, and of course the swollen lymph nodes. But along with that, there is a history of contact, known prior contact with a confirmed case in the 21 days before symptom onset. So there is a history of contact, and then there are various virus illnesses. The features of the virus illness, that is the exhaustion, fever, headache, muscle aches, joint pain. So these all are there. But remember, here we are looking at the possible case. So what is very important in this particular case is that in these patients, no rash is there, because once the rash is there, then it becomes the probable case, right? It's not the possible. So possible means the rash is not there, but all the viral features are there and the history of contact is there. Now, any illness where the clinician has a suspicion of mpox, such as unexplained lesions are there, but they are not limited to only single parts. Like they are not limited to the genital, anogenital or oral regions. For example, ulcers, nodules or proctitis. For example, anorectal pain and bleeding. So there are some illness along with the rashes, but we do not have a history of contact. This is the possible case, or the other possible cases where we do not have a rash, we have an illness, but there is a history of contact. So now you know that we are looking at three things. First is the illness, that is fever, myalgia, which are all related to the viral illnesses along with lymphadenopathy. Secondly, we are looking at the rash. And thirdly, we are looking at the history, exposure history. So out of three, if two things are there, then it's a possible case. There is a possibility that this could be there. Now, what happens in the probable case, right? So next is the probable case. So probable means there is a high probability. So a probable case is defined as anyone with the unexplained rash or lesions on any part of the body, but he has a epidemiological link. So here the illness, the rash is there, and the link, epidemiological or the contact link, is also there. So what three things we talked about in our last slide? That we are looking at the illness, we are looking at the rash, and we are looking at the contact. So if out of three, two were present, then we said it is a possible case. But if out of three, all three are present, then we have a probable case. So probable case, that is possible case with rash and history of contact also. So the probable case will have all the three things together. What is highly probable? So highly probable is where the orthopox virus PCR test is positive, right? So orthopox virus PCR positive result with all the things of the probable case. So highly probable case will be the probable case plus orthopox virus PCR positive result, right? So what is highly probable case? Can you write in the live chat what it is? So you can just write what you have got it from this. Highly probable case is, yes, probable case plus the probable case plus the orthopox virus PCR positive result. Very good. That's the perfect thing to know. Now, confirmed case. So confirmed case is now, instead of the orthopox virus, we have done the mpox PCR, and that is becoming positive, right? So when that is becoming positive, then it is known as the confirmed case. So these are the various case scenarios here. Now coming to what are the maternal complications in the severe illness. So how about the illnesses? What do you think about the illness? What do you know about the features of the illness? You can just write in the live chat so that I know you know the basics. I know you all know what all things we need, we see in the viral illnesses. So as I mentioned, we see the fever. Many of the patients may be actually asymptomatic, or they may have a mild symptoms, right? But mild symptoms are what? Patient may have some amount of fever, myalgia, fatigue, or it will be taken by the patient as a routine viral illness, and not, if any rash is not visible, the patient may not even be concerned about that. But when the illness becomes severe, which actually we can see in the patients who are immunocompromised, and we all know that pregnancy is one of those conditions. And we being the gynecologists, we are concerned about the obstetrics things. So maternal complications can occur in a pregnant woman. So for us, it is important to know, even if it is not common, but when it happens, what are the things which can give the severity to the patient? So severe refractory pain, commonly proctitis, eye disease, which can range from mild to severe, including the conjunctivitis, blepharitis, keratitis, corneal ulcer, corneal scarring, and rarely the loss of vision. Severe secondary bacterial infections or co-infection with a sexually transmitted infection. Numerous lesions, approximately more than 100, are those that require surgical intervention. Lesions associated with complications due to pain or swelling. Example, constipation, urinary retention, or inability to swallow. Encephalitis, pneumonitis. So overall, what all is getting affected? The rectum is getting affected, the eye is getting affected, bacterial infections can come up, or there can be other co-infections with the STIs, numerous lesions, multiple lesions, up to 100 lesions also you can see. And for those, you may require the surgical intervention. That is, you need to remove by burning or doing the ablations. Lesions associated with the complications due to pain or swelling, like constipation, urinary retention, or inability to swallow, brain, encephalitis, and pneumonitis. So all these can get, you can get severity because of these things, right? So now, what are the fetal risks, right? So what are the fetal risks? This is very important because we need to know about the trimester 5 risks and how we will monitor the fetus for those risks. So first trimester risk can be miscarriage, and you can counsel the patient about the symptoms of the miscarriage. You can tell them that if they see these symptoms, they can come back to us. So what are those? They are the vaginal bleeding and the pelvic pain, which can be there. Now, this can be because of the vertical transmission, and vertical transmission can later on also produce the effects which are not seen in the first trimester, but you will see those effects in the second trimester. So, the risk of vertical transmission still remains. To provide the reassurance with regards to vertical transmission, that the risk is very, very low. That do occur. We don't say that doesn't occur. That do occur, but the risk is very, very low. So the tests with which we can test whether the vertical transmission has occurred or not are not the routinely advised tests. So what are the tests which we can do to see if the vertical transmission has occurred or not? That is, you can take the fluid from the baby, that is the amniotic fluid, and do the mpox PCR from that. So that will be like you are doing the amniocentesis. So amniocentesis can be done in the second trimester for these patients, but as I said, the incidence of the vertical transmission is very, very low. So we do not advise amniocentesis routinely to all the patients who are tested positive for mpox PCR. Instead of doing the amniocentesis, what we can do is we can monitor the patient by doing the ultrasounds, because the effects like the preterm birth, the growth restrictions, sudden IUD, they are more evitable on the ultrasounds. So therefore, ultrasound is a better tool here. So in first trimester, it is important to do the ultrasound scan to assess the progression and the viability of pregnancy, because as I said, patient can go into miscarriage anytime. So therefore, we need to see the viability of the pregnancy. In second trimester, we may require the series of scans, which is like obstetric ultrasound with the estimated fetal weight, amniotic fluid volume, and the presence of fetal signs of infection, that is the hydrops. Third is preterm birth and the intrauterine death. Consult women regarding the reduced fetal movements, weekly evaluation with the ultrasound Doppler. So you can consult the woman regarding the reduced fetal movements, and you can also do the weekly evaluation with the ultrasound Doppler. So this is important because there is going to be the SGA. So how do we monitor the patients of SGA? We monitor them by the Doppler ultrasounds, that is umbilical artery Doppler. So that is what is recommendation here. So looking at the trimester specific risk, the advice for the fetal monitoring will depend on that. Now, what are the symptoms of the mpox? If at all the patient is symptomatic, what are the things we can see for her? So first thing is, after the exposure, it takes 5 to 13 days, right? 5 to 13 days post-exposure to show the symptom. So 5 to 13 days is the window period for these patients. Now, after that, prodromal phase occurs. So what happens in the prodromal phase? There is myalgia, fatigue, fever, headache, and the regional lymphadenopathy. Many a times, regional lymphadenopathy may actually precede the onset of myalgia, fatigue, etc. So myalgia, fatigue, fever, headache, general viral symptoms, and regional lymphadenopathy, they are the signs and they are the symptoms of the prodromal phase. After the prodromal phase, vesicular phase rash may either occur simultaneously or may occur slightly with the overlap between the two. So what happens in the vesicular phase? There are well-circumcised lesions which appear 1 to 4 days after the onset of the fever. So 1 to 4 days after the onset of the fever, they are initially the macules, then they form the pustules, okay, which then rupture and form the scabs. And it takes almost 4 weeks to heal. So patient can remain infective up to the 4 weeks when all the lesions, they dry up and the scabs are formed and they are crusted and they fall off. So till that time, this all process can take up to 4 weeks. So till all the scabs has been crusted and they have fallen off, till that time the patient can be infective. Now, what about the diagnosis? So, how the diagnosis is done? So, routine screening of the asymptomatic pregnant women is not recommended because this is not a very common condition. Exposure history. Exposure history is very, very important. If the patient has come to you with the symptoms of the monkeypox and you see that and you think that your clinical suspicion gives you the idea that it can be monkeypox, so you have to go for the to ask in detail about the exposure history. So what points are important in the exposure history? Has she traveled to any of the places where this is endemic? Like in the places Central Africa. So these types of places, if she has traveled or she has been in contact with anyone who was diagnosed case of mpox or who was also showing the signs and symptoms of mpox, has she had any sexual contact with such person? Any contact with the bedding or clothing of such person is also important. So the complete exposure history should be taken. Full examination of the skin, including the oral and vaginal mucosa and the perineal area, should take place because the mucus lesions can occur in the mouth, the vagina, and the anal region. Lymph nodes should also be examined, and polymerase chain reaction testing should take place in the discussion with the multidisciplinary team. So that's an important thing here. The following samples should be taken. So what are the swabs which need to be taken for the mpox PCR? So multiple swab samples should be taken from the open sores or the vesicles. Wherever you see the vesicles or the open sores or the lesions on the skin, samples should be taken from them and they can be placed in the viral transport medium. The viral throat swab for the mpox PCR can also be taken. So throat swab and this swabs from the multiple open sores and the vesicles, and they should be stored in a specific viral transport medium. Now, who all are included in the multidisciplinary team? Very important question, particularly for our part 3 candidates. So MDT discussions regarding mpox should include the virologist or the microbiologist, that is the infectious disease consultant. Along with that, obstetrician is required, neonatologist or the pediatrician, midwife, and plus minus anesthetist, depending on if the patient is nearing the delivery or he is in a critical care. So virologist, microbiologist, infectious disease consultant, obstetrician, neonatologist, pediatrician, midwife, and plus minus anesthetist. Remember, this MDT team is for everyone. This is not just for the severe. Once the patient is diagnosed that she is having mpox or she is a probable case of mpox, then she has to go with all these things. All the multidisciplinary team will come into action. Of course, because this is a case of mpox, so most of the things will be virtual unless and until the patient really requires the admission in the hospital. Now, we'll come to the point when she needs admission. But before that, I would like to talk about the prophylaxis, right? So if the patient is exposed, do we have a post-exposure prophylaxis for that? Yes, we have the post-exposure prophylaxis. That is, there is a modified Vaccinia Ankara Bavarian Nordic vaccine, which is basically is a recommended vaccine which can be given in pregnancy. Although we do not have enough data, but still the studies have shown that there is no teratogenicity with this, so we can give this vaccine to the patients. Modified Vaccinia Ankara Bavarian Nordic vaccine. In this, basically, the virus does not replicate. The virus, it has the content that does not replicate in the body, so it is quite safe in the pregnancy. It should be given within 4 days of the exposure, but maximally, if this is not given in the 4 days, then you can give it up to the 14 days as well. Now, once the patient is diagnosed, right, she is in the primary care. So what happens in the primary care? In pregnancy, if someone is concerned that they may have mpox, they should be referred to the local genitourinary medicine clinic or the infectious disease specialist. because they are the ones who are going to make the arrangements for these patients. Okay. So these are the ones who are going to make the arrangements. This can be done by the GP, midwife, or the obstetrician. If the pregnant woman concerned, they have mpox in the active labor, then midwife will take over and she will alert the maternity unit at their local hospital. And the complete MDT, which we just talked about one slide before, they will come into action for this particular patient. Now, how to treat? Once you've confirmed that the patient is mpox, how to treat these patients? So we can divide these patients into two, that is the mild or moderate mpox and the severe mpox. So what happens in mild and moderate mpox? So at home management, what management is done at home is regular virtual contact. As I told you right now, that if she is not seriously ill, we are not going to admit her to the hospital. We are going to manage that patient virtually. So regular virtual contact with infection team and the community midwife, and advice on rash management. So antipyretics, analgesics, they may be required, and you have to give advice on the rash management, what she can do for her rash. Public health protection team can assess the contacts for vaccination need, because all the contacts, they can receive the post-exposure vaccination and counsel on the risks in the pregnancy and the self-care, and where she can go if she develops the signs and symptoms which are severe. So first thing is, she will be managed virtually if she is mild to moderate. Secondly, she will receive the antipyretics or the analgesics as per requirement. She will be advised about the rash management, and a post-exposure vaccination can be given to her contacts. And third, next is you have to counsel her for the signs, the severity, signs, and symptoms, and she should know where to contact in emergency. Now, what is the care of rash? So, advice on the safe use of analgesics and pregnancy should be given. Nails should be kept short to avoid damage when itching. Topical anesthetics such as topical lidocaine can be used on the vesicles. Mouthwash containing the lidocaine 1% is recommended for the oral lesions. And if there are any markers of severe disease, consider the hospital admission. So you are basically using the topical agents to relieve the pain in the lesions. And then what are the markers of the severe disease that we already talk about, like eye lesions, encephalitis, pneumonia, multiple lesions, up to 100 lesions. So that completely thing we need to take care of here. Now, if we know that the patient has a severe mpox, then how to treat this patient? So one part is that she needs the supportive care. That is the basic care for the viral illness. Second thing is she also needs the obstetric monitoring. So this is important to remember it point-wise, okay? So here we know that one is the basic support care, and one is the obstetric monitoring. So for the basic supportive care, as per the symptoms, she might need analgesia, antipyretics, antihistaminics. So these may be needed, or you have to do the regular observation. So timely observation, if patient is admitted, at least 3 times you have to monitor the vital parameters for her. IV fluids are required depending on how much level of intake she can have, and according to that, you can plan the parenteral nutrition. VT prophylaxis is important because patient is in the hospital and is in bed. Oxygen, if at all it is required, like if she is having the severe respiratory conditions, then she may require oxygen as well. Rash management, I've already discussed, like short nails and the topical anesthesia. Now, what is the obstetric monitoring? So if the pregnancy is beyond 26 weeks, then there is a role of CTG. So CTG, if obstetrically indicated, you can consider the ultrasound assessment according to trimester. So the same management as we discussed for the fetal risk, that is in first trimester, we have to go for the confirm the viability. Second, you have to check the fetal biometry and detailed anatomy scan and amniotic fluid measurement. And third, as second plus fetal doctor. Antiviral treatment may be considered in unwell pregnant women in discussion with the infection MTT. So remember the 3 columns here: best supportive care, obstetric monitoring, and finally the antiviral treatment. So all these needs to be taken care of. Now, what is the management in the secondary care? So these severe patients will be managed in the secondary care. Pregnant women with severe mpox infection or complex obstetric conditions should be admitted to the hospital. This should ideally be in a center that provides the infectious diseases medicine, fetal medicine, and obstetrics. So that's why we need obstetrics MDT team here. Now, what about the labor and birth? So mpox infection alone is not an indication for the iatrogenic preterm delivery. Patient can go into preterm labor because of the infection, but this is not itself an indication for the preterm delivery. But if there is any maternal or fetal compromise, then we may need to consider the baby. But fetal compromise is fine. We always need to do that to deliver the baby. But for the maternal, you will have to see. Sometimes the early delivery may actually deteriorate the mother's condition. So you may like to first stabilize the mother. So that's very important. So urgent delivery in the mother is a question mark. You have to be in touch with the MDT for that. Magnesium sulfate can be used in the patients who are, if you are delivering the preterm, any baby, the preterm in the range of when to use the magnesium sulfate. Corticosteroids in discussion with the MDT you can give, because corticosteroids will have a good benefit for the baby, but for the mother who is having a severe illness, this may actually deteriorate the condition. So the final discussion can be taken with the MDT. What is the mode of birth? Cesarean section or normal delivery? So what is it? So basically in cesarean section, it is that in the cesarean section, it is not an indication. Mpox is not an indication for the cesarean section, but genital lesions. If there are genital lesions, active genital lesions, then you may prefer going for the cesarean section because that will reduce the chance of the baby getting this virus. Otherwise, patient can go for the normal vaginal delivery, but again, that is completely, you have to make a shared decision. Because like if the baby is affected by the vertical transmission, that is already occurred. We can't do anything now. And if there are no any genital lesions, then less likely to have a baby to get the infection during the delivery. But sometimes there could be asymptomatic lesions which patient is not knowing about. So in that case, there could be a risk of infection. So we do not have a clear thing for that, but if the genital lesions are there, then cesarean section is indicated. Otherwise, you can just see the patient's condition accordingly. You can take the decision about it, looking at the maternal health, the obstetric conditions. Now, what about the delayed cord clamping? That's perfectly fine. Here also we can go ahead with the delayed cord clamping, and that it does not increase the risk of the baby carrying the virus from the mother. Now, what about the post-birth neonatal and the maternal care? Specialist advice should be sought, and the pediatric infectious disease team should be included. A baby born to the woman with a confirmed or suspected mpox should be considered infectious until a negative PCR test excludes the infection. Neonates should be tested for mpox infection. The PCR of the throat swab, blood, urine, and swabs of any vesicular rash. So baby born to the woman with a confirmed virus illness should be considered infectious until and unless that shows that the baby has a negative PCR. Again, the same things, you can take the throat swab, you can take the blood, urine, or the swabs from any vesicular rash. So if the baby is not infected, and to reduce the risk of infection, mother and baby should ideally be separated at birth. So if the baby is not infected, and to reduce the risk of infection, and mother and baby should be separated till you confirm whether the baby has a test positive or negative. If the baby also gets the test positive, then both are positive, so both they can stay together. But if the baby is negative, then ideally they should stay separate. And secondly, if the baby is confirmed negative, then you can give baby the post-exposure prophylaxis as well with the same vaccine. Now, what about the breastfeeding? So breastfeeding is not recommended unless both mother and child are infected. Okay, so breastfeeding is not recommended unless both mother and child are infected. What does this mean? Because if the mother is positive and the baby is also positive, so in that case, they can breastfeed. But if the mother is positive, baby is negative, then it's a no. Right? So donor milk or the formula feeding can be considered. And the asymptomatic contacts of the people with mpox should not donate breast milk within 21 days of exposure to ensure they are not infected. So again, remember, if you are taking milk from any donor, that donor may not be, should not be in contact with any person with the signs of mpox for last 21 days. That should be very, very sure. So overall, if the mother is positive, baby is negative, no breastfeeding should be done. Now, role of antivirals. We do not have any specific antivirals, but these are the three antivirals which act. So they are tecovirimat, brincidofovir, and the cidofovir, right? So tecovirimat, brincidofovir, and the cidofovir, they are the drugs which can be used. But again, remember that we do not have enough data to use these medications in the pregnancy. Out of these, only tecovirimat is recommended to be given. Not exactly, I can say recommended, but there is some evidence to use this drug because the teratogenicity has not been seen with this in the pregnancy. But still, as I said, we do not have enough evidence to make a recommendation for these. But the other two drugs are certainly not to be used in pregnancy. So antiviral actually does not have a much role, can only be used in the severely affected patients and with the MTT approval. What about the future pregnancies and contraception? So a postpartum woman who has had mpox in pregnancy should be advised there is currently no evidence of any risk to future pregnancies once recovered. So once the illness is over, patient is better, there is no risk. And contraception should be offered to the postpartum woman as a part of routine postnatal care, and there is no contraindication to any kind of contraceptive measure. So all these you can use for these patients. What about staff exposure? Of course, throughout the care, they will be using the PPE kits and they will be following the guidelines. But still, if the exposure occurs, then what to do? Immediately inform their line manager and the occupational health. They should be immediately taken care of. Now, throughout all this, we know that when the patient is being managed, she will be in isolation and she has to stay for 4 weeks in the isolation. It's a long time, right? Maybe 2 weeks, 3 weeks, 4 weeks. So he needs a proper psychological support. So taking care of the mental health and talking about the support is a very important point if you are a Part 3 candidate. Once you are talking about this, don't forget to talk about the isolation and the support which she will be requiring when she is under the care. So that was about this monkeypox virus. So just to revise the few things, I would like all of you to answer these few things in the chat box. So my first question is, how many days after the exposure patient may go into the prodromal phase? I repeat my question. How many days after exposure patient may go into the prodromal phase? Kindly answer in the live chat. I'll be happy to see your answers. Yes. So what would be the correct answer here? Yes. 5 to 13 days. 5 to 13 days. And my next question is, when does the vesicular rash appears? When does the vesicular rash appears? When does the vesicular rash appears? That's the perfect thing. So when does the vesicular rash appears? My next question is, when does the vesicular rash appears? So it's 1 to 4 days after the onset of fever, usually. Okay. So another next important question to be discussed here. When to use the vaccine? Do we use it as a pre-exposure or post-exposure? Yeah, the vaccine is used as a post-exposure prophylaxis, and it should be best given in first 4 days. If at all the patient is not there in the first 4 days, then she can receive the vaccine for the up to the 14 days as well. Great. So once the patient is suspicious about the mpox, right, or she is suspected to have the mpox, to which department she should be, or which clinics she should be referred, who all should be involved? Okay, so those who need to be involved are, first is, yes, genitourinary medicine clinic and the infectious disease clinic. Genitourinary medicine clinic and the infectious disease consultants. They need to take care of her. Very good. So once we talk about the fetal risk, right? How we can detect the vertical transmission? What is the way we can detect the vertical transmission? We can do the amniocentesis to look for mpox PCR, but because the risk of vertical transmission is very, very low, so we will not prefer that. Rather, we will choose the ultrasound. So how we do the fetal monitoring in these patients? The way, the tool used to do the fetal monitoring in these patients is ultrasound scan, right? So for the first trimester, we do the viability scans. For the second trimester, we do the ultrasound scan for the umbilical artery Doppler, estimated fetal weight, and amniotic fluid volume. And for the third trimester, we can look at the series. Yes, perfect. I can see very correct answers in the live chat. I'm so happy to see that. So now I think you all remember. And what comes in the management? It is analgesics, antipyretics, the care of the rash, antihistaminics can be given. If she is in the hospital, then she may need the IV fluids also, because if she is vomiting, not able to take, you may give IV fluids. And VTE risk assessment, because she is in the hospital. So don't forget that. And for obstetric complications, you may need to do the CTG monitoring. And for the mode of delivery, cesarean only when there are genital lesions. Otherwise, patient can go for the normal delivery. And for the postpartum care, breastfeeding not allowed. Only allowed if both the mother and baby are positive. And every baby who is delivering for the positive mother should go for the testing. And again, the testing will be same, the throat swab from the blood, urine, or the stools, and you have to do the mpox PCR. So great. I hope now you remember. You don't need to revise it again and again, and you can remember the points for your exam. Thank you so much for joining today, and never estimate the importance of small steps. So this is also one small step in your exam preparation. And if you want to practice or read with us, because we believe in taking the small steps, and if you just want to sum up these small steps and make it for the ladder of success, then you are welcome to study with us in 70% less study time with MRCOG courses. So thank you so much for joining today, and you can just let me know in the live chat what all topics you would like to go further, would like me to talk about. So I'll certainly do that. Thank you.